In 94, Andrew Allen actually published the first tunnel technique. It was a supraperiosteal with no coronal advancement, but it was a tunnel treating multiple teeth. To me, that was the beginning of the tunnel technique. The technique that's more like we do it now was first introduced in 98 by Robert Zi and Daniel Etienne, but it was still supraperiosteal. Because if you think about how we grafted back in that time period, we were doing it by reflexing a flap by split thickness to create a vascular bed. And we sutured the graft to that vascular bed and, of course, over an exposed root. It wasn't vascular, but it was important to have blood supply to the graft. So typically, grafting involved exposure of a vascular bed. So that's the reason it was a supraperiosteal dissection. They also used bonded contacts in order to have suspensory sutures for treating class 3 recession. To me, this is important to understand some of the background. Zablaguet also published about the same time, essentially the same procedure, supraperiosteal dissection once again. I published in 99 a supraperiosteal method for the mandibular anterior, simply tunneling the midline papilla. I'll show you that in a moment. In 2001, one of the early tunnel publications, and the first one where they used the term modified tunnel. And that term really bothers me today because you see that used, and there's all kinds of variations of the tunnel technique. But this was the first one he called modified. I'm not sure exactly what he modified. It was still supraperiosteal, but this was one of the first uses of submarginal vertical incisions, often referred today to as vista incisions, but it's just simply a submarginal vertical. He used that to facilitate graft placement, not for site prep. In 2006, I published the alternate papilla incision tunnel technique that involves subperiosteal dissection, so that the graft was placed on a bony bed, a very rigid bed, and also apical to that, supraperiosteal dissection to improve mobility. In 2007, I call this the modification period, and it was a microsurgical technique. I'm going to see if I can get these. I can't get these off of here. With again, supraperiosteal dissection. But that's where MCAT was first used. And it's interesting today, you see a lot of studies and they say, it's the MCAT, the technique used was the MCAT. Well, there's not a single MCAT. There's just lots of variations, and you really need to know exactly how a procedure was done in order to interpret the results. In 2010, I published the subpapillary continuous zinc suture technique. I sent you that article. In 2011 was when the VISTA technique was introduced by Hamazadeh. And it's a tunnel also. And he used also, as I had done, subperiosteal dissection, and he used a submarginal vertical incision to facilitate site prep, and that's quite useful. Many times I find I should have done that in the past. I wasn't, of course, familiar with that technique in the early days. And he used a bonded suture technique to advance the tunnel well coronal to the CEJ, and I feel that's really not necessary personally. In 2018, I published with Tony Sculian the lateral closure tunnel method, and that was a sub and supraperiosteal dissection. And 2020, I published the papilla access tunnel that's really impacted what I do. I've been doing it for at least 10 years. On occasion, and I apply it now pretty much routinely in the lower anterior, and once again, sub and supraperiosteal dissection. And then most recently, in 24, I published with Kevin Murphy and Tony Sculian something I've started to refer to as the palate tunnel technique, because it's a combination of the papilla access tunnel with a lateral closed tunnel. And I'll show you that. I think it's to me, my go-to procedure for the lower anterior pretty routinely. I don't know what you see in your residencies, but the main problems that are referred to me involve significant recession in the lower anterior. So it's been fun to develop a procedure that I think is more successful there. So I'll show you a bit about the technique. This is generalized recession in a patient that I use in one of my courses as a demonstration surgery, treated as two separate quadrants just for demonstration purposes, but you see pretty advanced recession. This is his upper left, the first quadrant I treated pre-op, and sutured here with the coronal border of the graft showing. You want to cover the graft completely. Sometimes you don't quite get it completely covered. A millimeter or less is not a problem. It survives quite well. And now I'm applying the recombinant PTGF-BB, and I want to apply it between the graft and the root. So I use the end-cutting intracellular knife to tip that tissue back and act as a slide to add a drop or two of the PTGF-BB into the sulcus. I found this to be remarkably effective. I only have been using this about 3 years. Prior to this, I used PRP. I don't use that anymore. So 10 days post-surgical, you see complete root coverage with minimal inflammation. And it's, I think, largely due to, of course, partly the technique, but largely due to the PTGF-BB. Been very impressed with it. And a 6-month outcome with complete root coverage. And then if you look at the pre-op, again, both sides, it's 4 weeks post-op on the right, essentially done the same way. All tunnel, no vestibular access necessary because you have deep recession. And where you have deep recession, you really don't need a submarginal vertical to provide additional access for site prep and graft placement. But you see minimal inflammation, complete root coverage, nice outcome in a complex case. So I'd like to talk about the suturing because to me this is one of the main features of the procedure, and I use a continuous subpapillary sling suture to bring both the overlying tissue and the graft to the CEJ simultaneously. So I will start at the most posterior tooth, engage 4 millimeters off the margin at the root line angle, exit through the sulcus, and go through the embrasure, around the tooth, palatally, back to the facial, through the mesial embrasure. And then the next key step, instead of going to the distal of the next tooth directly, I go under the papilla so that I don't compress it. So this is really important step in this sling suture. Now that allows you to continue this suture at the distal of each tooth that you're treating until you get to the most anterior tooth. And then you will get the mesial aspect and work your way back to the starting point. So pass under the papilla to get to the next tooth, then penetrate 4 millimeters off the margin at the root line angle, exit through the sulcus once again, go through the embrasure, distal to the tooth, around the palatal aspect, back to the facial, through the mesial embrasure to reach the next tooth. You have to go under the papilla once again. And you do that until you get to the final tooth. And at the final tooth, you will engage at the mesial, so you do not want to go under the papilla at the final tooth that you're treating. So if that's the point, I will engage 4 millimeters off the margin at the mesial root line angle. It's important that you're at the root line angles. The reason for that is that you will advance both coronally and proximally, and you'll have a very ideal adaptation of the margin at the CEJ. It might be a little bit over the CEJ, but my intention is not to advance it multiple millimeters coronal to the CEJ. We can talk about that in the questions if you like. So you work your way back to the starting point by going under the papillae at each tooth to get to the mesial aspect, penetrate overlying tissue and graft together. And then when you get to the final tooth, you gently tie it, and you have a nice adaptation. So another tip about the suturing, you'll need to snug this tissue up as you go, because you can't wait till the end and try to pull it all together. I use a 6-0 polypropylene suture with a C17 needle, and I find that effective. I use 7-0 occasionally, but primarily 6-0. You have to be really cautious with this, that you don't injure the suture when you're passing the needle between the teeth, because you have a loop around the tooth each time you go from posterior to anterior. You have a loop around every tooth. So when you go back, you might injure the suture with the side of the needle, and then it can break. So you just have to be careful about that. A couple of examples. This is multiple maxillary teeth. It's going to be a reconstruction case. So root prep is done. At this time, I was using PRP. I don't do that now. I needed 2 grafts. These are allografts, and they've been soaked in PRP, introduced through the sulcus, and I do a continuous sling suture from each posterior quadrant. So there's 2 sling sutures here. And then you see a 2-week outcome. And minimal inflammation, once again, complete root coverage. Patient has a really easy time even treating the entire upper arch at one time. And then in 18 months, the patient has final crowns. They were placed 6 months after the surgery. And you see 12 months after the restoration is 18 after the surgery. And you see pre-op 18 months and 10 years. And you can see that there's been maintenance of the tissue margin at the restoration margin over that time period. Posterior mandibles can easily manage that too. I don't treat as many of those now because it's not referred to me. I'll treat what gets referred. I had one this week where I treated a posterior area, including an implant in a molar position. But here, the thing that's really nice is they're great papillae. So you have a good environment for the graft, and it's inserted, sutured in a similar fashion, and you see a 2-week outcome, and 2 years and 8 years. It's being maintained. This patient's in my routine follow-up care, and that's 15 years. So it's complete root coverage maintained, thickness of the tissue maintained, and a long-term outcome. Anterior mandible. I hear that you can't do this in the anterior. It's motivating to me when I hear that. And a lot of people like to use a free graft here. I've not used a free graft in the lower anterior for teeth in more than 25 years. I did a lot of them in the past. I completed my dental school training in 1969. And those of you who know the literature know that's about 6 years after the free graft was first described. So I did a lot of free grafts up until the probably early 80s when the connective tissue graft was described. And it's a great procedure, but it's not so great for the patient, and it's to me unnecessary. So you see the graft on the surface, inserted suture. Of that, so you can appreciate complete root coverage. There is a KT gain. I don't typically measure that. And clearly thickened tissue, as you see a reduction of the appearance of prominent roots. So it's pretty obvious that there's a good outcome in that area. So let's look at the anterior mandible. That's my thrust. And the challenges that we have there, we can address and find solutions for. And you see the challenges. It will take the first 2 together, muscle pull and frenal attachment. And the problem with that is retraction. And to me, that's the reason that many people quit using the connective tissue graft in the anterior mandible, is because of the nature of the site prep. You did a horizontal incision through all of the papillae, dropped verticals, dissected a flap, and put that flap over the graft, sutured it, and it would retract. And the healing was not so good as in almost any other area of the mouth. So a lot of people abandoned the connective tissue graft method in favor of the free graft. To me, the problem was retraction. The solution is tunnel. So I'll show you the very first one I did, and look at the conventional treatment here first. And what we were doing in the beginning was a trapdoor outline, horizontal incision through all the papillae to reflect that tissue, and then put it back over the graft. My plan is to tunnel, to change that technique, to tunnel that midline papilla, and otherwise incisions are very similar, but this allows us to mitigate the tension. So this was published in '99. I mentioned that. You see a schematic drawing of it and the actual clinical view. And in the clinical view, the key is tunneling that midline papilla. And it's amazing the stability, the wound stability that can be achieved by doing this. In fact, that view that you're seeing, cheek retractors are in place and you see no retraction. And then you can move those pedicles over so that they are on the part of the graft that's over the root where there's no blood supply. So you have a surface blood supply. And it's easy to place the graft. Suturing, you just bring the pedicles to the midline and suture to the tissue, and you can essentially have primary closure. It's kind of messy looking, but the cheek retractors are in place here once again. You see no retraction. This is 5-0 chromic gut suture. It's an old technique. And at 2 weeks, no retraction. So wound stability leads to pretty normal healing, uneventful healing. 4 weeks looks good, 6 months, and 20 years. So it's an effective method. Where there is mucosal flap over the palatal connective tissue graft, there is no change in that mucosa to keratinize. So that's a false, I think, interpretation. A lot of data shows what happens when you do things like this. We can go into that, but it would take a lot of time. I don't want to spend right now. So let's look at this example. Generalized recession here, very strong frenal attachment, no attached gingiva, and the tissue's thin. So the treatment's going to be a tunnel, once again, treating all of the incisors, the canines, and the left premolar. That's sutured with the human acellular dermal matrix within the tunnel. You see a little bit of graft exposure, not much. You see one knot on the left side, so that's where the suture started. Continuous sling. By going under the papillae, there's no compression of the papillae. By suturing at the root line angles, you advance and have a better adaptation to the CEJ. And that's a 6-month outcome. It's not great. This is typical. There's a range that you see over time. But if we look at pre-op in 4 years, we see quite a significant change. And we compare pre-op 4 years, we see complete root coverage, KT gain, increase in tissue thickness, frenum is displaced, and there's a normal vestibule. And I can demonstrate that here at a 12-year post-op, where I'm manipulating the vestibule, and you see the frenum does not pull the marginal tissue. It's simply been displaced into a normal position with a gain of attached gingiva and maintenance of root coverage. So shallow vestibule, you hear, well, you can't do a tunnel where there's a shallow vestibule. In fact, you may hear that if you do a tunnel that you'll reduce vestibular depth. Well, if you do it by a sharp dissection, that's true. But I don't. I do blunt dissection, subperiosteal for 8 millimeters, apical to the CEJ, and then sharp dissection that's immediately supraperiosteal, leaving only the periosteum for an additional 7 millimeters. That allows a passive advancement. And by the blunt dissection, I create a rigid bed that the graft adapts to, attaches to, and the overlying mucosa attaches to that fixed graft, and you extend the vestibule. So we'll see that in this case. So there's a bit of a difficult site here. A lot of things going on. The central incisors are extruded. There's a lot of abrasion of the roots, thin tissue, shallow vestibule, broad frenal attachment, a number of things. Really narrow papillae, they won't support the graft very well. So I still will tunnel this, and we will plant composites for the central incisors, because I expect to be able to cover the lateral incisors, and the tissue on the central should be level with the laterals. So place the graft and suture it. Unfortunately, the midline papilla that was very delicate separated, so there's a little retraction at 4 weeks. That improved. You see pre-op in 2 years with the composites in place. The composites were placed at 6 months after the surgery. And if we look at a lateral view where you can see the vestibular form with just cheek retraction, finger retraction to demonstrate that, you see pre-op. You see the outcome after grafting before composites are placed at 6 months. And then you see the form of the vestibule at 2 years. And at 5 years. So that extension of the vestibule has been maintained, and there's normal form of the frenal attachment. So how does this work? It works because of the way we do the dissection. It's important that you do a blunt dissection, subperiosteal, create a bed that the graft will attach to the bone, so it's rigid. That will displace the frenum internally, and it will also displace minor muscle attachments, maybe a bit of the mentalis. And this results in a deepening of the vestibule. So let's look at deep recession. This is what led us to the lateral closure technique. And it's obviously a difficulty in doing a coronal advancement in the mandibular anterior region anyway, but when there's deep recession, it's even more difficult. So our idea is to correct that, or to solve that by doing lateral closure. And I'd like to show you this from the past. This is Cohen and Ross, 1968. And they introduced the double papilla flap, which was really interesting, difficult to do as a single procedure, particularly in those days when we didn't have the microsurgical techniques we have today. But they freshened the margin, as you see on the left view, and sutured that together. And that resulted in a movement of the lateral keratinized tissue to the midline and gave you a gain of KT. So this was a nice advantage. So we do something similar. Reported this with Tony Sculian in 2018. And you see what I refer to as connective tissue graft positioning sutures. You simply have to insert the connective tissue graft within the site and secure it at each end. You don't have to do that with allografts. They're easier to handle. But the problem was securing the graft first, and you see a suture ghosted behind the one central incisor with a deeper recession, and that will snug the graft up to the CEJ. Otherwise, it's not going to be positioned and stabilized, and then do the lateral closure. I've changed that, so don't pay a lot of attention to this at this moment. This is one of Tony's cases, deep recession. I've ghosted in the suture that secures the graft to the CEJ of the tooth with recession. You see the positioning sutures, connective tissue graft positioning sutures, and a sling suture on the opposite central incisor. And that's the way we were doing it at that time. Sling sutures, interrupted slings on adjacent teeth, no sling on the tooth with the lateral closure. And once again, I've changed this. Something about this bothered me, and I'll show you the correction. And so that's the outcome. Nice result with Tony. This is the rest of the cases will be mine. Our publication was all connective tissue grafts. They were all Tony's cases in that publication. But here you see that reactive tissue lateral to the recession, and you can see a demarcation between that red inflamed reactive tissue and the tissue that used to be adjacent to the tooth. To me, that is an outgrowth of reactive tissue due to a proximal exposure of the root. And it's very delicate. It falls apart when we do the procedure. So here, again, I don't want to go through the suturing here because I've changed it, but I was able to do the lateral closure. You want to do at least a 3 millimeter bite. In other words, 3 millimeters away from the margin when you're doing the lateral closure, and maybe 2 to 3 millimeters between sutures. That part is less precise for me, and a simple 6-month outcome in that case. Interesting patient. I had changed a little bit at this stage, so show the suturing, and then big change is using 7-0 polypropylene suture. That's what I use routinely now for the lateral closure. You still will use 6-0 for the sling, but the lateral closure itself you really need a smaller suture. A 10-day post-op, it's okay. Sutures for the lateral closure were removed at 10 days, and then you see a 2-month outcome. I generally leave my sling suture for 2 months, and I do because it causes no irritation. It's more comfortable for the patient to remove it when the tissue is more mature, and the patients aren't bothered by it. So the tissue's not irritated, the patient's not irritated, and it's more comfortable. This is 8 months, and there's not root exposure there, but I was worried about that margin a little bit. This is after we cleaned it. I didn't see him for 2 years. He moved out of state, and he came back. He was not an oral athlete, what I like to say. He didn't do a good job with cleaning his teeth. So my first reaction was, wow, even with the challenge of the plaque and calculus, there's no breakdown of that tissue. And then I thought about it more, and I thought, well, maybe, the main cause of breakdown is aggressive brushing. That's why you get recession to start with. So maybe not brushing helped that tissue stay. I don't know. But it stayed. We cleaned it same day. That's the same appearance, a little bit better than it looked at 8 months. So we'll talk about tooth position, malposition as a factor. This is a change because not so long ago, we in all of our world workshops, we said you graft first and ortho second, and we've changed that a bit. So you're seeing a post-orthodontic recession on the central. It's extruded. It has a fixed retainer. I learned from Zucchelli that his theory on this is that the function on that incisor causes a rotation about the fulcrum of that retainer wire and causes the root to project anteriorly. So it comes out of the ridge a bit and you get recession. So we want to move it back. And the patient also has a chin implant, had orthodontic surgery, so there's scarring, some other issues here. But if you want to analyze this, I find if you look from behind the patient at the lingual surfaces of the lower incisors, you see less of the lingual face of the tooth that has been torqued anteriorly. So the root's been torqued anteriorly. And you can, of course, see it from a buccal view or a facial view. So we want to align that root first and graft with lateral closure second. This is the alignment. You see the before, comparing the amount of lingual face that you see before and then lined up more after. Also buccally, I think you can see the slightly different angles in those photos, but you get the point. And what you generally see too is an improvement in the width of the root exposure, sometimes also the height of it. And also the occlusion has been adjusted so there's no longer premature contact with that lateral incisor. With that central incisor. This is a week after surgery with lateral closure, and at 3 years, what you'll see is significant change. This was class 3 Miller class 3 recession, so it's not 100% root coverage, but you can also see quite a change in thickness as well as tissue position at the 3-year post-op mark. So this is a paper by Leandro Zambroni, a review indicating that cellular dermal matrix is it's a good alternative to palatal tissue in patients who've had orthodontic treatment. And if you're looking at phenotype modification, which I'll talk more about in a moment if we don't run out of time, I don't know how your time is. Shallow recession is difficult because you have thin tissue, typically prominent roots, irregular bony topography, and more importantly, a narrow sulcular perimeter. So access is difficult. This is where the VISTA technique would have I think, an important role for site prep. I didn't do that. I was treating these, of course, before the VISTA technique was described, and I was able to treat this. It's just difficult. I don't do it through the sulcus alone anymore. But that's a 1 month, a 3 month, 4 years, 7 years, and pre-op in 10 years. So thicker tissue, complete root coverage maintained for 10 years. This is the Papilla Access Tunnel technique published in 2020. And the idea is rather than making a submarginal vertical, I incise the papilla, just the facial layer of it, between the canine and the lateral incisor. It is selected because it has the largest tissue volume, it has the most robust blood supply, and most importantly, has the least tension. So you can gain access, dissect under the 3 midline papillae, do not incise them, because they are there to control the tension in the site and provide wound stability. So you incise this on both sides, and you can tunnel through the open papilla across the midline. It facilitates the access to tunnel without risk of injuring that tissue. Plus, it's faster. A lot of reasons to do it. For me, this is routine. You can also pick up posterior teeth through that same opening. I find it personally easier than the submarginal vertical. If you like that way, that's fine too. A sharp dissection with the arrowhead knife, and then follow with the Orban knife to complete the 7 millimeters of additional dissection that is supraperiosteal. The initial dissection is subperiosteal. That's the graft on the surface. inserted easily through the open papilla. This really made a difference for the lower anterior. This takes just, less than a minute. Align it, and then suture. I made this is, again, early on. You can close the incised papillae with the continuous sling suture. I did not know that at this time, so I just put an extra suture in to close the papillae. And that's a 24-hour post-op. What I'd like you to see here is how clean that site looks, how there's minimal inflammation, minimal swelling, because you can do a really gentle site prep and graft placement, and you can do it faster. So there's just less trauma to the tissue. And you see a pre-op and 6 month post-op. Probably the first one I did that way is here. And just this significant root prominence and undercuts intradentally, shallow recession, thin tissue, difficult site to treat without some sort of access. So I did the papilla access, and that gives you little mini flaps, little W flaps for access. Once again, you see the graft on the surface, graft inserted, single continuous sling suture. Back again in those days, I was doing the extra suture to close the papilla. And you see complete root coverage, of course, thicker tissue, and that you just don't see the root prominence. It's only 4 weeks, so it's a bit of swelling that hides that. But here you see it at 5 years and 15 years, and that covering of the roots and a thick tissue beneath is evidenced by not seeing that root prominence. So I think it's pretty obvious you have thicker tissue. And it's lasted so far 15 years. So that brings us to what I do now. And I think we have a few minutes that I can cover this. The combination of the papilla access with lateral closure. And this was a bit of a tongue-in-cheek acronym for me, because I just think some of the acronyms are humorous, put it that way, and interesting. So this is papilla access, PA, lateral closure, LAT. So now when people say, do you ever use the palate? I'll say I use it all the time for the lower anterior. I use the palate technique for the lower anterior, not a free graft. So papillary incisions, as I showed you, you want to make sure you leave papillary vascular beds, and that gives you, again, access. You can dissect through the papillary opening or through the deep recession. And the difference is that after I do the complete site prep, I do the lateral closure. It's simpler to do it without a graft underneath it. We didn't do it before because we needed that opening to place the graft. If we have papillary access, that eliminates that problem. Then the graft is easily inserted. And once again, when you have the graft inserted, you want to make sure you do not extend it over the vascular bed for the surgical papilla. And it often wants to migrate onto that vascular bed, and that is not good. It will not heal well. So you just manage that in suturing. And then the continuous sling suture includes the tooth with the lateral closure. And that gives you much more stability, and it actually advances it a bit more in that location. Just a millimeter or two can make a difference. And if you worry about cutting the lateral closure sutures, you just simply avoid them by starting your penetration lateral to the suture or apical to those sutures. And once you penetrate the graft, your needle is behind the graft. Those sutures are on top of the graft. They're just closing the surface tissue. They don't contact the graft. So your only risk of cutting it is when you place it, and as you exit, sometimes you can exit through the sulcus and catch one of those sutures, but you shouldn't. The graft protects it. The positioning of those sutures is a little bit wider than root line angle, and that's okay because you don't need to advance it much. The rationale for placing the suture at the root line angles is to have ideal adaptation at the CEJ. So where you don't have recession, that's less critical. And also the suture over the incised papilla, it's the same thing. You want to go over the top of it, so you position your suture at the midpoint beneath that papilla, so it closes it with that one continuous sling suture. So there's a lot of little minor points here that make a big difference, and you get a good outcome. This is a very recent case, so I've incised both papillae, sutured it with a continuous sling suture. You'll notice the suture's a little wider at the tooth with the lateral closure. And at 2 weeks, the sutures kind of disappear because they get engulfed by the tissue as it swells. And then you see a full week outcome and a nice stable tissue. So it heals rather quickly. The incised papillae, you can't tell that it was done. It's quite simple. And it's to show you a live, more or less, video here of how stable that site is. The freedom doesn't pull on the area. It's a very stable wound. This is all about wound stability. It makes a difference in treating it. This is the first case I did as a live surgical demonstration. It's approaching 3 years ago now. That's the end of surgery suture. There were some issues with this. It's not my best looking suture job, but it's okay. And that is a 24-hour post-op and 6 months. I'd like to also show you here, because I just shot this picture this week, and she's at 2.5 years currently, and you see complete root coverage. And because you're swinging the papilla tissue, the keratinized tissue in the papilla to the midline, you have a nice thick keratinized tissue margin. I think this is a real benefit of this technique in the lower anterior. And once again, I use this for shallow recession too, just to have a better outcome. I'm showing you this one because this is from a dentist who sent me these photos. She took my course a year ago. We do this procedure on a model. We teach it on a model in our hands-on workshop. But this is tough. This is side-by-side, deep recessions, central incisors. I mean, you look at the setting there, and how are you going to treat that? And this was, I don't know if it's her first case, but it was very early on. Her suturing's not ideal. She didn't close the papillae well. The papilla between the right lateral and central incisor separated, so it's sutured extra. And in spite of all that, she has a very nice 4-week outcome. So this is not a procedure that only someone who has some sort of special talent can do. It's learning the steps and performing them carefully. You'll get a good outcome. KT width, I may skip this. Tell me if you like. Let me just zap through it. Pre-op, sutured, and there's a gain of KT. Well, there's the mucogenital junction, and the point is the base of the graft is apical to that. So whether we gain KT or not is significant to me. You always gain a little bit. I think generally enough. And what you need to understand, of course, is that graft, no matter what it is, palatal tissue or a non-resorbable allograft, it does not send a signal through the mucosa to tell the epithelium to keratinize. That doesn't happen. So I think that the term keratinized tissue, or we need keratinized tissue, is overused. We need functional tissue. We need stable tissue. We need a lot of things. And the epithelium is an indicator of that in many cases, but I think it is a misused term. And then this paper supports this. Stavelli and co-authors published in 21. No significant differences in KT width observed over different bilaminar techniques, which is what we're speaking of with the tunnel, regardless of what you put in it. So you put palatal tissue or whatever you put in it, it's not going to change the epithelium. And so keratinized tissue is simply primary and secondary graft exposure. What you leave exposed, what becomes exposed from retraction of the flap, or it might be tissue that comes from the PDL and marrow spaces, it might not be from the graft at all. It also can be scar formation. So a lot of times you see publications say, look at the gain of keratinized tissue, and I say, look at the scar. And it's certainly not useful for covered grafts, for bilaminar technique. So I just want to show you a bit about phenotype modification. We used to say tissue thickness. This is an implant site. That's a long story that I'm going to skip. You see sutured 3 weeks and 4 months. I want to enlarge that so you can see the thick tissue at 4 months. And then at 4 years, I enlarge that, and you see that thickness of the allograft has been maintained for 4 years. So you can do phenotype modification, just a little bit more difficult to evaluate. But I'll show you that with teeth here. You see pre-op and the allograft on the surface, inserted and sutured. And you'll see a 6-month, 18-month, and 12-year outcome. And if you look, you can see when you stretch with a cheek retractor, you can see the outline of that graft in each of those time frames. So the thickness of the tissue, the phenotype modification is achieved with an allograft that doesn't resorb. If you use some that resorb, of course, you won't get that. Allograft phenotype modification, there's 25 years of evidence. I can send you this slide, or you probably get it if you're recording this. Those are some examples of it. So what we talked about with the anterior mandible are the challenges. Muscle pull tunnel corrects that, eliminates the tension. A femur attachment, we do internal detachment. A shallow vestibule, you want to do blunt dissection, create a rigid bed that will extend the vestibule. Deep recession we solve with lateral closure. Tooth malposition, we now do ortho first. Shallow recession, I use papillary access, and I use it pretty much routinely for the lower anterior, not just shallow recession, certainly with the lateral closure as well. And with thin meat phenotype, use a non-resorbable graft. So with that, I thank you for your attention. Sorry about the little bit of a delay in starting. And you can follow me on Instagram. I post cases that are interesting, and I post my vacations that are more interesting. So it was a pleasure to visit with you a little bit. I take any questions that you have time for. I love the question and answer period, so I'm going to turn it over to moderator, and we'll see where we go.